In this video, we are going to discuss the cardiovascular system and all the points that are related to the cardiovascular system. Theory and the MCQs both are discussed in this video. Let's talk about roughly point 75 that is related to the lipoproteins. Lipoproteins have been classified on the basis of their densities into 5 major classes. So there is chylomicrons, there is very low density lipoproteins, then there is intermediate density lipoproteins, low density lipoprotein, and the high density lipoprotein, that is HDL. So it's very important for you to remember that LDL is lousy, LDL is bad because it enables excess cholesterol to build up in the body. Whereas HDL is healthy, it is good because it carries extra cholesterol back to the liver where it can be eliminated. So this was simple about the HDL and the LDL. Another important thing about the HDL and the LDL is that the highest cholesterol is present in the LDL and the lowest is present in the chylomicron. The highest protein is present in the HDL and the lowest is present in the chylomicron. Highest phospholipid is also present like protein in the HDL and the lowest is present in the chylomicron. Whereas the highest triglyceride is present in the chylomicron because chylomicron is responsible to deliver dietary triglyceride to the peripheral tissues, right? Whereas very low density lipoprotein deliver the hepatic triglyceride to the peripheral tissues. This is the only difference, that is going to carry the dietary triglyceride, the chylomicron, whereas the hepatic triglyceride are carried by the very low density lipoproteins. So the highest concentration of the triglyceride is present in chylomicron, and then there is VLDL and LDL, and the lowest is present in the HDL, whereas protein and phospholipids are highest in the HDL. Now let's talk about the few the disorders, or before doing the disorder, the major lipoprotein source of the cholesterol is used in the cell is LDL, is the answer, the major source of cholesterol. Now let's discuss few disorders, type 1 hyperlipoproteinemia and type 2 which is familial hypercholesteremia. The type 1 familial hyperlipoproteinemia is due to deficiency of a lipoprotein lipase or ApoC2 with increase in chylomicrons and triglyceride. Whereas the other one, the type 2 cholesteremia, is due to the defective LDL receptors with high LDL and cholesterol level. So in type 1 hyperlipoproteinemia, there is deficiency of lipoprotein lipase or ApoC2, and that is going to cause increase in triglyceride and chylomicron. And in type 2 hypercholesteremia, there are defective LDL receptors, and that is going to cause high LDL and cholesterol level. Now I'll quickly discuss the MCQs. Type 1 hyperlipidemia is going to cause increased level of chylomicron and triglycerides and cholesterol. Type 1 alpha hyperlipidemia occurs due to decrease lipoprotein lipase. Lipoprotein with highest fraction of protein is HDL. A 56-year-old executive after eating burger with fries carries lipid profile done. After centrifuge, his plasma appeared milky white. So that is due to the chylomicrons. Which of the following is associated with increased risk of death in a cardiac patient? Which of the following is associated with increased risk of death in cardiac patient with positive family history of hyperlipidemia? That is LDL. Which lipoprotein is found in abundance in blood? That is the HDL. HDL is present in abundance in the blood. Lack of LDL receptor occurring type 2 hyperlipidemia. Factor inhibiting fibrinolysis related to coronary artery disease is factor inhibiting fibrinolysis is LDL-C. Let's talk about roughly point 74, which is related to the vessels of the cardiovascular system, that is arteries, arteriole, capillaries, venules and veins. We are going to discuss the MCQs and only the important point related to the vessels. So the MCQs that are asked for veins and venules is the greatest percentage of blood volume is found in the veins or venules. That is repeatedly asked. Moreover, the vascular smooth muscle of the circulatory structure, which is controlled almost exclusively by the nervous system, is venules. Veins carry the blood towards the heart, and the blood volume contained in the vein is the unstressed volume, and they have the alpha-1 androgenic receptor. In response to compensation of hemorrhage, what is going to decrease? Venous capacitance going to decrease in response to the hemorrhage. For the arterioles, the greatest pressure drop in the circulation occur across the arterioles because they have the greatest resistance. They are the point of the highest resistance in the cardiovascular system, and they are the smallest branches of the arteries. They are regulated by the autonomic nervous system. Alpha-1 androgenic receptors are found on the arterioles of the skin, splanchnic and renal circulation, whereas in beta-2, androgenic receptors are found on the arterioles of the skeletal muscle. So this is important that beta-2 is present on the skeletal muscle, whereas skin, splanchnic and renal, they have alpha-1 receptors. Greatest resistance is present in the arterioles. Alright. Now we see autonomic sympathetic nervous system mainly involve arterioles. The other question is, the hypertensive patient presented with eye problem and was diagnosed with the hypertensive retinopathy. Which of the following is the target of hypertension retina? That is the arterioles. Arterioles are targeted in the retina in the hypertensive patient. Patient is a known case of chronic hypertension with decreased visual acuity, and the most likely affected area is the arterioles. Now, the evidence that the arteriole offer more resistance to blood flow than any other blood vessel is the pressure drop across them is greater than that across the other vessels. So that is why the resistance is more in the arterioles. Increase in both renal blood flow and GFR are caused by the dilation of the afferent arterioles. The major short-term action of angiotensin II is vasoconstriction of arterioles. Alright, so one of the classified function of kidney is regulation of the blood pressure through renin angiotensin aldosterone mechanism. Angiotensin II mainly causes the vasoconstriction of arterioles, right? So the major short-term action of the angiotensin II is to cause the vasoconstriction of the arterioles. Then there is another MCQ. Pressure in the glomerular capillaries is higher than the other capillaries. Why? Because the afferent arterioles are short. It's important for you to remember the function of the angiotensin II and the MCQs that are related to the GFR and the renal blood flow. Moreover, there is an MCQ, the most likely variable which decreases in response. The most likely variable which decreases in response to a decrease in arterial blood pressure is the neural activity in the carotid sinus nerve. So now we are going to talk about the capillaries. One of the following has the highest total cross-sectional area, that is the capillaries. Then there is the maximum pressure from systole falls at arterioles capillary junction. Alright. Then the spread of the tumor to the lymph node. Tumor to the lymph node is via the capillaries. The inside of the glomerulus is composed of tuft of capillaries. Let's discuss roughly point 72, which is about the edema. So you need to remember that the increase in hydrostatic pressure is going to favor the filtration, whereas increase in capillary oncotic pressure or colloid osmotic pressure is going to oppose filtration. This is one point which you need to remember. The second point which you need to remember is that whenever there is a cause of edema, ask in the MCQ in congestive heart failure, edema, pulmonary edema, or any pedal edema, then the answer is going to be increase in hydrostatic pressure. There are multiple MCQs that are asked for this, and the answer is the increased hydrostatic pressure. So increased hydrostatic pressure most commonly can result from the cardiac failure. There are few MCQs that are related to the colloid osmotic pressure or oncotic pressure. A 5-year-old child will generalize edema and proteinuria of 3.6 grams. So whenever there is a mentioning of edema and proteinuria, the answer is going to be decreased colloid osmotic pressure. The cause of edema and liver cirrhosis is due to deficiency of albumin. An adult will generalize edema in the urinary protein. This damage is done to the basement membrane. In case of nephrotic syndrome, the most common cause of edema is hypoalbuminemia or hypoproteinemia. A patient has edema, skin lesion, and apathic. The cause of edema is decreased level of albumin. Patient has jaundice, edema, and ascites. The cause of edema or the accumulation of fluid in the abdomen is result of hypoalbuminemia. A patient has periorbital edema. The mechanism is hypoalbuminemia with salt retention. Some proteins are filtered through the glomerular membrane only in minute amount because their filtration is opposed mainly by strong negative charges in proteoglycans of the basal membrane. There is very little protein in the glomerular filtrate. This is because all serum proteins are too large to fit through the glomerular pores, and also because of the combination of pore size and negative charges that line the pores. An increased glomerular filtration rate by a drug is most likely by increased hydrostatic pressure in the Bowman space. If GFR increases, proximal tubular reabsorption of salt and water will increase by a process called glomerular tubular balance. The most likely contribution to this process would be an increase in peritubular oncotic pressure. Formation of the interstitial fluid increases with decreased plasma colloidosmotic pressure. A lady drowned in water. She was taken out and resuscitated, and she developed ARDS. The most likely mechanism is pulmonary interstitial edema. A 50-year-old man known to have hepatoma developed dependent edema with dilated abdominal wall vein. The most likely structure involved in this patient is inferior vena cava. Which of the factors do not cause increase in edema? So the answer is going to be arteriolar constriction. Let's talk about roughly point 71. So it's about the exercise effect on the body. So there are two systems that are affected by exercise. That is, one is the CVS system and one is the respiratory system. So in the CVS system, exercise is going to increase the blood flow. That will occur with increase in the central command. The blood flow is going to increase via the central command as well as the local response. So if you see on the CVS system, the central command is going to increase in the sympathetic outflow, and there is going to decrease in the parasympathetic. So simple is there is going to increase in heart rate, increase in contractility, there is going to increase the stroke volume and the cardiac output, and it is also going to cause a constriction of the arterioles, and that is going to cause decreased total peripheral resistance, and that is going to cause increase in the pulse pressure, and the constriction of the arteriole decreases the TPR, total peripheral resistance, and the pulse pressure is going to increase as the stroke volume is going to increase. So there is also going to be veins constriction as well, and that is going to increase the venous return. Local response is going to be, there is going to be dilation due to metabolites. During exercise, the muscles respond to the metabolites. So there is going to be a dilation due to the carbon dioxide, hydrogen ion, adenosine, lactate, and potassium ion, and there is also going to be dilation of the skeletal arteriole. So there is going to decrease in total peripheral resistance of in the skeletal muscles. Alright, you see in the MCQs that during which of the following parameters decrease during moderate exercise. So that is TPR. So overall the TPR is going to decrease. Moreover, a patient with low cardiac reserve is asked to perform an exercise tolerance test. Which of the following will be most likely observed? The failure of the cardiac output to raise to meet the activity demands. During exercise increase, which of the following increase in stroke volume? Increase in arterial pressure with decreased total peripheral resistance is due to exercise. A man working in a well-ventilated room starts sweating profusely. BP was high, pulse was tachycardic. The most temperature was high. The most likely cause is exercise. After stress or exercise, what will be different in left and right systolic or diastolic duration? So during exercise, the heart rate is going to increase. So there is going to be decreased diastolic, and there is going to be increase in the systolic. Most important subjective cause of a person feeling exhausted during exercise is increase in the heart rate. In exercise, blood flow is increased to skeletal muscle, TPR is decreased, right? During exercise, there is decreased blood flow to kidneys. If the option is kidney is there, then you have to choose kidney. But if kidney is not there, then you have to choose planking, right? And patient having increased right atrial pressure, an increase in the systemic pressure, and decrease in the venous resistance, and that is basically due to exercise. Decrease mean arterial pressure, decrease resistance to venous return, that is also in exercise. And you have to remember, in exercise, blood flow is increased to which organ via stimulation of the sympathetic. So in exercise, only the skin, because local metabolites are active in the skeletal muscle. It is maintained by increased contractility. Now let's talk about the effect, exercise effect on the respiratory system. So expiration is going to increase. The hemoglobin oxygen curve is going to shift towards the right side. Exercising muscle, there is going to be increase in carbon dioxide production and increase in oxygen consumption. So there is going to be increased ventilation rate to match the oxygen consumption and carbon dioxide production in exercising muscle, right? In exercise, there is going to be increase in cardiac output as a result of increase in pulmonary blood flow, and ventilation perfusion become more uniform because there is going to be increase in the pulmonary blood flow and increase in ventilation rate as well. So this ratio, ventilation perfusion ratio, become more uniform from apex to the lungs. So if MCQs is asked that an athlete is involved in regular exercise, during exercise in blood, the blood flow in all zone of the lung is like zone 3 of lungs. A person doing regular exercise, what factor in this condition increases respiratory rate? So there is going to be proprioceptors that are going to cause the increase in respiratory rate. Let's talk about Ruffy point 70, that is related to vasculitis. So there are three types of vasculitis: large vessel vasculitis, medium size vasculitis, and small size vasculitis. So let's first talk about the large vessel vasculitis. And the most important is the giant cell, that is also known as temporal arteritis, and the other one is Mcqs arteritis. So the most common granulomatous inflammation is the giant cell. Its common size temporal and ophthalmic artery. The clinical finding is a unilateral throbbing headache with jaw claudication and may lead to irreversible blindness due to ophthalmic artery occlusion. It is associated with polymyalgia rheumatica, and the diagnosis is a temporal artery biopsy. And Mcqs arteritis is a pulseless disease, that is weak upper extremity pulses, granulomatous thickening and narrowing of the aortic arch and the proximal great vessels. So a 55-year-old may present with right-sided headache, visual disturbance, temporal artery is firm and tender, and thus it was biopsied. So what is the probable diagnosis? The answer is going to be giant cell arteritis. Now let's talk about the medium-sized vasculitis, that is polyarteritis nodosa and the Kawasaki disease. The polyarteritis nodosa is typically involved renal and the visceral vessels, and it does not involve the pulmonary vessels. Then there is hepatitis B. Seropositivity in 30% of the patient is present in the patients of polyarteritis nodosa. Kawasaki disease is the self-limiting disease that is also known as mucocutaneous lymph node syndrome. Fever, hemorrhage, also called mucocutaneous lymph node syndrome, Kawasaki disease, and it is associated with fever, hemorrhagic edema of conjunctiva, lips, and oral mucosa, and cervical and lymphadenopathy, and it may develop coronary artery aneurysms, thrombosis, or rupture, and can cause death. May develop aneurysms, thrombosis, rupture, and can cause death. It is self-limiting disease, and it is also known as mucocutaneous lymph node syndrome. Let's discuss MCQs. Polyarteritis nodosa is diagnosed by fibrinoid necrosis. Microscopic diagnosis of polyarteritis nodosa vasculitis in female is by fibrinoid necrosis in arterioles. Polyarteritis nodosa is associated with Hep B. And a 6-year-old Japanese boy was brought to ER with severe chest pain while playing. On examination, he has severe conjunctivitis, lip edema. He is suspected to have an aortic aneurysm. What is the probable diagnosis? The diagnosis is Kawasaki disease. And it also comes as, so there is edema, there is conjunctivitis, and there is also suspected to have aneurysms. So a 9-month-old Japanese boy brought to ER with conjunctivitis, edema, and cervical lymphadenopathy and aneurysm. Then the diagnosis is Kawasaki disease. Now small size vasculitis are ANCA positive, CANCA positive, and PANCA positive. The one with the C is the Wegener's granulomatosis, whereas the one with the P is the macroscopic polyangiitis and Church-Strauss syndrome. So the one with the CANCA is the Wegener's granulomatosis, and the MCQs related to the Wegener granulomvasculitis. The most diagnostic feature of the Wegener granulomavasculitis is fibrinoid necrosis. CANCA is associated with Wegener granulomatosis. That is the anti-neutrophilic cytoplasmic antibodies present in generalized, you can say, vasculitis if it's the only option. About the PNCM vasculitis, is associated with, if there is no correct option, then you have to choose hepatitis B. So this was all about the MCQs related to vasculitis for your FCPS exam. So remember, if any vasculitis, you have to take fibrinide necrosis. In this video, we are going to talk about Ruffy point 73 and we are going to talk about shock. So what is shock? Shock is an inadequate organ perfusion and delivery of nutrients necessary for normal tissue and cellular function. So it's inadequate organ perfusion as well as delivery of nutrients. So there are 4 types of shock: hypovolemic, cardiogenic, obstructive and septic shock. The names are self-explanatory. Hemorrhage, dehydration, burns are the causes of hypovolemic shock. Acute MI, heart failure, valvular dysfunction, arrhythmias are the causes of cardiogenic shock. Cardiac tamponade, pulmonary embolism, tension, pneumothorax, they are basically the causes of obstructive shock. And sepsis is the cause of sepsis causes septic shock. In all the types of shocks, the skin is going to be cold and clammy, except in septic shock, the skin is going to be warm. The other differences are that the cardiac output is going to be decreased in all type of shock except in the septic shock, where it is going to be increased. Therefore, the oxygen delivery is going to be increased in septic shock and decreased in all other type of shock. Moreover, in septic shock, there is vasodilation. So therefore, the systemic vascular resistance is going to be decreased. Whereas in other types of shock, the systemic vascular resistance is going to be increased. Moreover, the heart rate is going to be increased in all type of shock, and the venous return, that is preload, is going to be decreased commonly in septic shock and hypovolemic shock, but it can be increased in cardiogenic or obstructive shock. So let's discuss MCQs now. Vasodilation and hypotension are the feature of septic shock, right? So these are the distinguishing feature of the septic shock. Moreover, the poor prognostic factor in septic shock is DIC. There is one more type of shock, that is a neurogenic shock, that we have not discussed. So neurogenic shock occurs due to loss of vasomotor tone. And neurogenic shock is associated with decreased systemic filling pressure. An old patient after abdominal surgery developed abdominal distension. On examination, he was pale and BP was low and tachycardic. Most likely cause of shock is, so he has abdominal distension, he had an abdominal surgery, and his BP was low and he was tachycardic, and he had a abdominal distension, so the most likely is hypovolemic shock. The best parameter for fluid recitation in hypovolemic shock is increase in urine output. Anaphylactic shock differ from the hypovolemic shock by increase in cardiac output. So anaphylactic shock is like a septic shock. Now about the cardiogenic shock. In myocardial infarction, which type of shock is seen? Simple is cardiogenic shock. Now a few more MCQs. A patient after accidental bruise on thigh present to you in the ER. On examination, the wound is foul smelling and the patient is hypertensive. So the diagnosis is going to be a toxic shock syndrome. So it's a foul smelling wound and the patient is hypertensive. It's a shock condition and that is toxic shock syndrome. A young boy developed fever, hypertension and erythematous patches all over the trunks. Toxic involved is erythrogenic toxin. That is the toxin of the toxic shock syndrome and the scarlet fever. So erythematous patches and hypertension and fever. Now DIC is caused by endotoxin shock. A patient with lacerated wound on thigh 1 week before presented now with foul smelly discharge. On examination, hypotensive, tachycardia and febrile. What is the likely diagnosis? That is a toxemic shock. A 45-year-old male presented to ER with fracture. Most likely causes excessive blood loss. Fracture of the pelvic bone. Immediate management of patient with multiple pelvic fracture, blood loss and shock includes IV fluids. Which of the following drug increases chronotropic and inotropic effect on the heart? Glucagon. If heart after pumping ought to be stopped to ensure circulatory system becomes static, the pressure measured in the rest of the body means systemic filling pressure. Now some debatable MCQs. A 30-year-old male was brought to emergency in a state of cardiogenic shock. The drug you would like to use would be dopamine. It also comes as 50-year-old presenting in ER with failing heart. Which drug of choice should be given? That is dopamine. A patient brought to ER in a state of shock, that is unrecordable BP with heart failure. Which neurotransmitter should be given? That is norepinephrine. norepinephrine, he is brought to the emergency in a state of cardiogenic shock, then you are going to say it is dopamine. Just if the person says heart failure or a cardiogenic shock, then dopamine. But if it also says that he has an unrecordable BP, he is in shock condition, then you are going to give norepinephrine. There were options as dobutamine, epinephrine, and dopamine, so you are going to select norepinephrine if the statement mentioned the state of shock as well. This is debatable. Here a simple method is used for shock and inotropes. This would be useful during your training as well. If initially BP is unrecordable, you are going to start with norepinephrine as it is a strong vasoconstrictor. So you want all the fluid from the body to be at heart. So you're going to start with norepinephrine. When BP is slightly recordable with systolic pressure around 80, switch from norepinephrine to dobutamine because now you want a vasoconstrictor plus also a good inotropic action, and the explanation goes on like when you would taper and how you would taper. Also when to use double inotropic sports, etc. So you're going to start with epinephrine when the blood pressure is unrecordable, and then you are going to give dobutamine.